Hello and welcome. And the issue today is NHIAs and the medicine problems. Now, you see, in the year 2000, when President Kufuor was campaigning for to become president, one of his campaign promises was that I will get rid of cash and carry if you give me the mandate. And so it came to pass that he got the mandate. And so in 2003 came the birth of the NHIS. Which became law, and then under that came the NHIA, who regulate and license all these other suppliers who will supply the medical chain. And it's gone on well, because back in the day, even those who went for emergency services literally had to pay upfront before your emergency cases will be looked at. So this has been one of the best schemes all over Africa. So it's a good thing that has to be protected. However, the Chamber of Pharmacy is saying that because of arrears, and maybe too much arrears in paying them in medicines they supply to hospitals, they are now cutting their supplies. Anyway, today it was like they would or they wouldn't, they would. But I have in the studio Stanley Ajay, who's head of research and advocacy at the Chamber of Pharmacy, to educate us on what the problem is. What's the big delay? Why don't just they supply? When I come back, we'll continue. My name is Nanan Sakwao, and this is PM Express.
Though the Chamber of Pharmacy ultimatum took effect from today, some community pharmacies who rely on them for their supply say they have had to bear the brunt of the action for some time now.
We will get our drugs from Osons, we will get some from NS Chemist, we will get some from Kena Pharma. They think that they are suffering too much because they are not getting their money to be able to pay their principal. I have already made my orders, and I'm hoping to be supplied by the close of the day or latest by tomorrow. West
Point Chemist, just like the other pharmacies who serve patients from Kolibu, Ghana's biggest health facility, and its environs, say the situation is already critical, but could get worse if nothing is done about it in the next few days.
Oh, I tell you, we can't go more than a week, because you could see the demand here is very, very high. People are waiting patiently to be supplied with their prescriptions. So if they don't, within a week, we would have to fold up. Less than a week, we would have to fold up.
People are using other people's money to do business. And if you take our institution, Raw Chemist, what is happening is that people have picked up medication from us and our money is locked up. So, yes, to our extent, they are justified, so that at the end of the day, if they are paid, we will also be paid.
The Kolibu Teaching Hospital also relies on the Chamber of Pharmacy for stocks. An official who would not want to be named, however, denies it will be affected. But the chairman of the Government and Hospital Pharmacists Association says there is no way Kolibu would be spared the impact of the supplies action.
You find out that most of our facilities now have about 80% of patients who come on NHIs. There are a lesser percentage who come and do cash and carry. And so if you realize that the chunk of the money that will be used to purchase these drugs actually going to NHIs, and NHIs is not reimbursing the facilities for them to be able to purchase the drugs or pay for the drugs that have been purchased. So most often than not, these drugs are actually given on a 90-day period, and so on a credit. So after the 90 days, if they are not paid, you put them into a very awful situation.
He also would not rule out a return to the cash and carry system as threatened by the community pharmacies.
That means that some NHI people will be denied their medicines unless they probably buy it on a cash and carry basis. And I don't think that will be very fair to the patient.
Meanwhile, pressure is already beginning to mount on the few pharmacies serving NHIA subscribers as more of the shops begin to run out of stocks.
They are owing us. In fact, last year they were able to pay us up to the month of June. So from July down to present time, they are yet to give us our checks. Though the bills that we have sent is up to November, we are yet to send our December bills. But the ones that have been vetted, the bill that we have submitted to the authority that have been vetted, they are yet to give us from July, August, September, October, November. They haven't given those monies to us.
Atani, Joynews.
Hello, so this is what brought about the topic for today. The pharmacy, Chamber of Pharmacy threatened to pull their services. And there are consequences if that happens. With me in the studio is Stanley Ajay, who's head of research and advocacy at the Chamber of Pharmacy. I keep calling Chamber of Commerce. You're welcome.
Thank you.
Very good. Stanley, the Chamber of Pharmacy, I mean, what body, what do you do and how do you come together?
Yeah, as a Chamber of Pharmacy represents the interests of pharmaceutical establishments in the country. Mm-hmm. So not to say we have all pharmaceutical establishments or our umbrellas, even though that's our ultimate. So we have some manufacturers as part of our food, we have distributors, and even some chemical shops. So in totality, we represent the broad sections of the pharmaceutical establishments.
Okay. What percentage do you have in terms of pharmacy? What percentage do you have? 30%, 40%?
By way of the suppliers, we have a chunk of them, and I can say up to about even 90%. It's the retailers that is proving a bit difficult. And in terms of the manufacturers, currently they do have an association. Mm-hmm. But the ultimate, though they have interest in ours, but the ultimate is to bring them also under our umbrella so that it will be the umbrella body for all the the pharmaceutical establishments. So
your main aim is just to fight like a common good?
For the common good of the pharmaceutical, with the view to developing a strong, dynamic pharmaceutical sector, best as we can. We are hoping for the sub-region.
But there are competitors amongst them?
In as much as they compete, in a lot of areas too, they share common interest. So as they compete fairly, they must also fight for their common cause.
Okay. Now, how many of you are registered to supply NHIA?
And like I said before, we have a lot of the suppliers or the drug distributors under our folds. And in Ghana, they constitute a chance of the manufacturing establishment, or they are major player. They serve as the link between manufacturers or even within Ghana and elsewhere. So they serve as the link. So without them, there even going to be a break in the chain. So we do represent their interests very much. And except in recent times, there has been some issues. That's why we are talking about their issues now. So if tomorrow it's about retailers or something about manufacturing crops up or comes up, you hear our voice, or we're working behind the scenes with the view to helping solve the issues.
Is it only manufacturers that supply the NHIA, or retailers also supply?
Is the suppliers, or what we normally call wholesalers and the distributors, that can supply in bulk. So they get contracts with the health facilities and they supply them at the unit level or individual level. So at the end of the day, a chemical or a distributor will have a lot of health facilities under which he has supplied drugs. So let's say pharmacy A or pharmaceutical company A supplies, say, more than 10, more than 20, depending on a business. So in how you get your business is not.
No, what I want to find out, like, do you have like a retail shop also supplying, or is only the manufacturing?
The retail shops that supply fall directly under a service provider. So now there may be a retail in, say, a town, a retail shop, being a pharmaceutical shop, where we do retailing, but they will be registered under health insurance. So assuming, say, you are in Tafo, say, in Eastern region, and there's a facility there, it will fall directly under a service provider, where subscribers of health insurance can go to the facility and get drugs for free, in quote, because they are under the health insurance. But over here, the issue is those that are supplied to the hospital.
We'll get there, but when I come back, then we need to go through the procedure as to, do I just walk in and pick my medicine, or does the hospital order and say, look, give me this amount? We'll go through all that procedure before we get to the payment section. Hello, so the education continues before we even get to the problems on the ground. Now, we're trying to differentiate between retail and manufacturing and how they play their role. Now, you're saying that with retail, the doctor writes me a prescription and I just go and pick it up. Yeah,
because it is a health insurance accredited service provider. So they work with the hospital. So a hospital in a particular community will have a pharmacy or a retail shop attached. So in the event they don't have it in their pharmaceutical shop at the hospital, then the subscriber can as well walk into the pharmacy shop and he will get his medicines under the scheme.
What will make somebody qualify, or what will make a shop qualify to become an accredited supplier?
They go through registration process, which the Health Insurance Authority will be best to give the details.
No sweat. And then the manufacturer is different. They supply directly to the hospital.
Not exactly. We are talking about the distributors here. Those ones that have the distributors, they have contracts with as many health facilities as a supplier can. So they will supply them directly to the hospital. So the expectation is that then they will get reimbursement for the service, and they will then get reimbursed, and they will onward pay to the suppliers.
So now we're going to go through the order and the payment scheme. So the hospital orders, or their standing orders, how does it work?
Normally hospitals and the suppliers, they normally do tender, or what we would normally call bidding process. So you do bidding, or they get register of suppliers, etc. So they then, after the bidding, they select their suppliers to supply. But the hospital may be having, or a medical facility may be having different suppliers on their program, because not all one supplier cannot be. So there are a number of them that may be on them. But it's a direct arrangement between the medical facility and the supplier, independent of Health Insurance Authority, except that they come in because it's a scheme they're operating under. They would have to pay the facility in order for them to pay their supplies.
I see. And then who do you submit your payment to? To the hospital or to NHIS directly? If I was a distributor.
So as a distributor, since your contract is directly with the health facility, you go for your money, or you chase your money, in quote, from the service providers, that's the hospitals and the clinics.
Oh, okay. So the hospital then has to chase
the NHIA for them to make payments, for them to be able to as well pay their supply.
And what's the problem now?
So now the problem, as we put across since last week, was that since in some cases, as we put across May 2013, and in majority of the cases from July 2013, the hospitals or the service providers have since not been reimbursed with the claims, and for that matter, they are unable to effect payments for the supplies we've made. And it's just unquestionable for us to be on their throat or to be chasing, because we really have a good idea of where or how the problem is, that they've since not supplying. They're unable to find money elsewhere to pay, except when payments are made to them. And the problem we put across is not that the health facilities don't pay us when they get the money from health, but that sometimes it takes time for it to go. So as soon as they get, there's no problem at all for them reimbursing the supplies.
I mean, because of the nature of the work, and you're dealing with a government entity, is it fair for us to ask you to be a bit more patient, because you know that by all means it will come, it's just delaying?
It's fair, because we are talking about human life here and the health of the people. And in the pharmaceutical business, sometimes there are two levels of motivation. You save life and maybe it's also a business. And in some cases, saving life even may take precedence even over the profit or the business side of it. But you get to a stage to where you become sort of helpless or helpless for the simple reason that you've been stretched to your limit. That's why we are not coming out a day or two after delays, but we are announcing or putting across a persistent delay. And for that matter, we do agree, because for the sake or for the health of the people, we might have to exercise some patience. But we are announcing a situation where it was equally in the interest of the patient that if nothing substantial comes, you may be heading towards a more greater doom, because the distributors and the suppliers will run or will go just to their limits that there will not even be even a single tab or syrup in their warehouse even to sustain or supply to the facility. So what we did is equally in the interest of the patient.
I mean, that is leading to my question that, how bad are things for your pharmacy?
So the how bad it is when the money stays. So as long as it stays, there's nothing being paid on it. And sometimes in the supplies work like trade financing. Maybe you get some you win some tender or you get some contracts, and you can even take a loan to supply, and you do your projections and calculations, and you can still make some margins on, in anticipation that payments will be forthcoming. But as there's delay, then your calculation or whatever you did may be thrown out of gear, and your interest as you used to supply will be piling. And sometimes it's not just even the interest, it might even be going into the capital. And it's even become more critical when there's some changes, the fluctuations, especially in the exchange rate. Like we all know, most of our drugs we supply is imported. So sometimes your calculations of your pricing is based on an exchange rate of, say, 2 cedi, say last year June, or 2.2 by last year June. By the time payments come, then we are talking about going to make imports based on exchange rate of, say, 2.6. Then by that time, it's really bad, and your capital is even under threat.
How are they making projections? I mean, what do you do? Add 20 cities, add a certain percentage. How do you, because I'm supplying you something today, and I know by all means you're not going to pay me now. And by the time you pay me, the CD has, might have depreciated 1%, 0.5%. So, I mean, how do your members make the projections so that they stay in business?
So by way of the projection, in as much as you can, sometimes you are overtaken by events, for the simple reason that sometimes some of the delays go beyond your any reasonable expectation or the normal expectation, as we may talk of. Then secondly, some of the happenings just happen without control. For example, in the recent depreciation, and is something that is almost not easy to predict. And aside this, because of the competition, you are unable to make so much projections or to put so much margins on because like I said, they go for base, and the expectation is that even however small the margin, because it's trade sort of thing, even when it comes, you may, but sometimes the projections get out of gear when the delay, so as long as there's delay, then the projections are getting out of gear.
What's the normal payment time? I mean, if everything goes well, what's the normal payment time?
There has been a recent health insurance law and Delali, and before the facilities were supposed to submit, or the accredited that health insurance service provided, they had 60 days within which to submit their claims. And when it goes to the health insurance, they also work within 4 weeks to supply, even though this was not. But in recent times, the recent LI make projections that when submission the claims are made, there is a stay, or let me put it, there's a period of about 3 months within which. So you made the projections based on the 3 months, but we get to a stage where it exceeds the 3 months, and then you do all means as possible to be able to address your shortfalls by way of capital or liquidity problems to supply, and sometimes you are stretching. You can't help but to wait for you to be paid in order to restore your operations to normalcy, as we find ourselves now in.
So from what I get you, that's what, like 80-day period to get your money?
Now,
Because you're saying 60 days and then they hold it for another 2 weeks?
That was the law until recent. That's how it was supposed to operate. That they have, so they were. It's not as if the service providers wait for 60 days. They were to submit it within 60 days. So some may submit it earlier. Then the health authority or health insurance was as well supposed to submit it within 4 weeks. So that's where, in terms of the timeline, especially on part of the health insurance authority, they were just unable, or they were persistently failing in that timeline.
The reason why I say that is because I think the NHIA is also saying that most of your members are not submitting in time. And if you go by the period to which they have to pay you guys, then probably they're only behind by 1 month, 2 months.
By the claim of health insurance that they are not submitting on time. If the situation is that there are pockets or particular ones that are not being paid for the simple reason that they've not been paid, then their case will be made stronger. But I'm talking about generality where none has been paid, unless they are suggesting that at some point in time, no service provider is able to make claims, is able to submit claims on time, and it cannot be the case, and it's not the case.
Let me, good evening, Salom. Salom Adenu is the Communication Director for NHIA. Salom?
Hi.
Good evening, brother.
Good evening, sir.
Well, I have Stanley Ajay, who's Head of Research and Advocacy at Chamber of Pharmacy here. We're obviously trying to find a middle ground so that, our dear old ladies and ill citizens will walk into hospital and get their paracetamol in peace. But you're not paying them in time.
You said you're not doing what?
You are not paying them in time.
Well, I mean, that's an interesting way to put a question.
I know.
But that's fine. Well, I've not been listening to the program. I wish I were. So if you indulge me, let me greet Stanley. Hi, Stanley, how are you?
I'm very well, Salom.
Well, it's the same.
I think you're doing a good job, trying to put the issues across, and I think that's what we need, more engagement and all. But, I just needed a few clarification on some issues, which will inform, what I would say on this program.
Okay, so
what is the status of your call at the moment? Because I heard on one platform that you guys said you were calling off your intended suspension. Is that a case, or you are still on with the suspension? Sorry.
So at this point in time, following the release that we are reliably informed is at the region going to the districts, and the assurance, that is the strong assurance, is coming from NHIA and government that within the next couple of days, another payments are forthcoming. And of course, in the interest of the subscribers, we are putting on hold the intended end action as we called. But except to add that, because of the liquidity or cash flow issues that we encountered, the wholesalers and the suppliers are not really in the position to restore their operations to optimal scale or maximum scale. For that matter, the subsequent release will be so important in order to get to normal supplies. So as at now, our position is that as far as we can, we will continue to supply, but except that we've been stretched, and in some cases our warehouses have run dry, so the subsequent payments necessarily will have to come in order to restore things to normalcy. Salom.
Thank you very much. The subsequent payments will certainly come. So, so we are on the same level.
Sure.
In the meantime, you've called off the intended suspension. In the meantime,
very well.
All right. Thank you very much. That's a very important point to make. But if I may also ask, what kind of payments are you looking at? What period, between what period and what period payments are you looking at before you restore service, optimally or fully?
Now, our understanding is about 2 months has been released. So maybe if another 2 months or something comes, it's going to go a long way to improve the liquidity of our people and the businessmen which we work for. And it will really help matters, and it means that we'll be getting somewhere with such payments coming. But
2 months takes you to which month? Because I have up to July.
Now our understanding, following Mr. Metokwame this morning, is that the payment that came covered July and August. So if September, October, and possibly November, but for now, if September and October can come within the next couple of days, as has been promised, it will go a long way to bring some stability into the operations, and they will be able to really sustain the supplies to levels as we all wish it happens for the health insurance to keep going.
Okay, good one, Sally. So to the point you make really is that I'm not sure if you heard me summarize well, but the payment release comes, the payment, cover the period August, September, not July, August, September. July was paid, some time back. August, September, that's a normal thing. Of course, if anybody complains of not being paid up to that period, then it means that facility has a problem. And very, very few facilities have problems. So, to put it on record, you pay August and September. And finally, you because you don't deal with you guys, quite directly, maybe I know you understand a few things about how our payment systems go. For example, we have said that we pay within 60 and 90 days, when we submit a claim. And if you look at that roughly, that is about 3 months. And as you see, people are still, generally just concluded, we just finished in January. January claims are still coming. So as you see, we don't have all claims for January. January figures are not even clear as you see. So effectively, you have just like December and November. Some still are even bringing December claims. But December, of course, we have quite a lot of that already. And November. So if you look at this 3 months, allowance we have by law, within which to be able to make payments, and you calculate it backwards, you realize that we will get to somewhere October. So if you're able to pay up to October, then pretty much we are on course. And we have now paid till September, which in our humble view, it's not a very terrible situation. It's appearing, you understand? I understand you guys are business people, and you make supplies, and so you are supposed to be paid. We are sorry about the delay. It's unfortunate. We hope it didn't even happen that way at all. Because what happens is that if it happens this way, it doesn't really help, the scheme at all. And we have also come here, this hasn't really happened before. We have also come here because of the growing confidence the people of Ghana are having in the National Health Insurance Scheme. Like I stated elsewhere, if you go to the hospital on every single day, for example, go to the hospital tomorrow morning, you realize that about 90% of the people who are at the OPD are going there on the account of the National Health Insurance Scheme. And that is a very huge, task to have, and that we are aware of. Which means, by extension, that, or even it's on record, that 85% of IGF, of internally generated funds, of all NHIS accredited hospitals or facilities, come from the NHIS, leaving between 10 and 15% to cash and carry. So what it means is that if the NHIS is late for a month or two, they can be doing so well, nobody will hear about like we've been doing. If it delays in payment for about a month or two, it means that the chunk of the facility, money has been locked up somewhere. And in business, there are calls and agitations make a lot of sense, because if somebody keeps a bulk of your source of income or of your revenue, you can't run. That is it. So it's like the NHIS has become a victim of its own success. Years ago, when the scheme just started, it was just about 10% of the entire idea, which was from NHIS. So if NHIS even defaulted for several months and it's not paying, the effect is not felt as it felt today. So what we must get, discussions we must start having as Ghanaians is that, how do we get more money to fund the NHIS? Because now we are about
Salam, I'll get to the how to get money, but I want to.
I'm just trying to deal with this.
Okay.
So, we need to. If I could just finish, we need to deal with this, and I'm cutting it there because I hope you see that issue. So we'll make a point there as well. But to get back to this issue, I said it's unfortunate we got into this situation, but of course we are a beneficiary of government resources. After when government made resources available, we make payments. It was coincidental that government released money and the statement from the chamber also came. Government released money on Friday and the statement came on Monday. And if you realize, from Monday, Tuesday, we've been making payments. This meant that we were ready, just awaiting the release of funds from government. So government made a release and we have since effected payments. And I'm happy Stanley is saying that they have indications to prove that some of the facilities are getting the money, and some also have indications that the money has been paid to the bank. So the banks are just going through their routine processes, and the money will hit their account, which means that we've been consistent with what we have been saying. And government has given an assurance that, in the next couple of weeks or months, they will release another chunk of our money with them. That is the NHIA, that is the levy collected, so we are able to settle all that. But again, in talking about the release of funds from government, we must also understand how government processes are in respect of money. Because, if the processes are not fully exhausted and there is an issue, I think you call government or call officials of government that is misapplied or misappropriated funds. So this is how it goes. NHIA does not collect the levy we pay goods and services. We don't collect that. There's a government agency called the GRA, the Ghana Revenue Authority, which makes that collection. To make that collection by a period, it deposits it in what we call a consolidated fund, which is a big kitty where government has its money. And it has other monies in that. So after a period, the Ministry of Finance will sit down and they will make disbursements. So for example, we have a component of the VAT which is to get funds. We have a component of other taxes which go to road funds, which go to the NHIS and everything. So they sit down and make those disbursements. But I've just said that in 2-3 minutes. But it takes a longer process to get that done. But of course, that is to be expected for developing countries. Sometimes the software, the IT system, people sitting down to do this and that, it takes quite a bit of time. Because sometimes a lot of these are done manually, and the technology sometimes is not the best. So as we are growing, it's the hope of all Ghanaians that we're able to use technology to advantage, IT to advantage, to quicken some of these processes. You understand? And so NHIS is just like any other government agency, any other department or agency of government, which suffers from the same delay of release of funds like any other. But because we are into health and our name is all over, the least thing is attract a lot of attention and a lot of media scrutiny.
Thank you.
That's why we are here where we are today. So it's unfortunate. Nobody wishes that it happens again. But we can only assure that we will do our best to ensure that the situation doesn't recur, and we will pay as and when government makes funds available. And government has been given an assurance that they will release money, and we are praying that the money to be released on time to be able to clear what is left.
Salam, because of the stakes involved, i.e., if pharmacy people get agitated and withdraw, and rightfully, because some say they borrow at 30% to supply, some borrow at 5% a month from microfinance to supply. Is there no shorter way in this computerized world to make these payments? 90 days is too long.
Yeah, we're talking about legal provision. And before any service provider joins the NHIA, they know. So these are the steps, and they know. So this is not a point to debate that or argue that it's a provision or a condition they agree to before they join. And you see, it's even improved. It has improved big time. It used to be months before these things are done. And again, the scheme is expanding. The scheme is not small. The scheme is expanding. In the last election, you saw how NHIS was used as a major political campaign tool because it's a social issue, it's a health matter. And any social intervention of any country, which has about 20% of the entire population in it, is a hot political bed. And NHIS is approaching about 40%. About 9.2 million people in Ghana are members of the scheme. By extension, every single household in the country has something to do with NHIS. Every single household.
And how many percent of this are paid?
I'm building a point. I'm building a point because I want the viewers to understand what we are.
Okay.
So if you have a system or you have something like the NHIS, which is free, at a very fast rate, you want to be able to put in place systems which will ensure that funds are not misappropriated, funds are not misapplied. In the past, what we have done is that we just release the money to the district, and the district pay their people. We do quite strict rules. But for the big ticket facilities like the Kolebu, the Kopanochis, the Rich Hospitals, the 37, the regional hospitals and all, we aggregate the claims and we take them to places we call the claim processing centers. And we have 4 of these claim processing centers dotted across the country. We have one which is the biggest in Accra. We call it the claim processing center in Joynews. We have one in Cape Coast which serves the coastal belt. We have one in Kumasi which serves the middle belt. And we have another one in Atani which serves the northern part of the country. And these claim processing centers are manned by very professional people, doctors, nurses, pharmacists, etc., who understand what treatment goes with what condition. So that if a facility or a doctor or someone writes another drug which is not on the NHIA list, they're able to take it out and you don't pay for it because we are not supposed to pay for drugs on our list. And a lot of things, sometimes, through auditing and things like that, it's a drug really come across instances where men are going to deliver through cesarean section. And all these regulations are made public or they come to the fore through the work of the Claims Processing Center and clinical audit, which we do. And again, to answer your question, we have introduced what we call the electronic claims management system. So you don't submit your claim manually. You submit a claim via an electronic system. And that takes just a few minutes to vet the claim. And for all facilities on the e-claim system, they get their money paid instantly. Once the claim gets vetted in a few hours or in a day, they get the payment effective to them. And as we speak, we have about 47 facilities, big facilities on e-claim. They call it Booth and Co. They are on e-claim. So it is our hope that by the end of the year, we will also have about 500 facilities on the e-claim system. Then we keep scaling up. So we have a huge part of the country covered by e-claim system. And I'm going to be quick to add that we will continue to have manual claims management. Because even in the US, a very advanced country, they have about 90% penetration for e-claims management and about 10% or so for manual claims. But this is Ghana. So we are trying our best to move to a system which will be faster. Because if you are not happy owing people, that is a positive aspect. I'm not happy having this conversation with you at this time. And I've been happier just having a conversation about the way forward for the NHIA.
Can I come in with a way? Let's move to the way forward a little bit. And
right.
You see, at the moment, you say we have 9.2 million people on the scheme.
Yeah.
Now, what's the percentage contribution of these 9.2 million? Is it still the normal 5% or has it increased?
Yes, I mean, it's between 4 and 5% of the total amount of money, of the total revenue of the NHIA. Premium payments is just about 4-5%. And you see, it is a social and it is a government social intervention program. So out of this population, about 70% do not pay premium. About 70% of these 9 million people I talked about do not pay premium. They do not pay premium. These are people we've identified as indigent, very poor, people who cannot pay by any stretch of the imagination. And government must take care of them. It's the duty of government to protect its people. So government gives them insurance cover. So government protects them. They don't pay. Pregnant women, we run a free maternal care system. They don't pay. Pregnant women in Ghana do not pay for any antenatal, postnatal, delivery, cesarean section. They don't pay. The state, the NHIA, takes it and pays for them. Children under 18 years, they don't pay. And if you understand our demographics, or look at Ghana's demographics, you realize that a chunk of the country's population are below 18 years. Mm-hmm. And all these people do not pay a pesewa in premium. We have people in special groups, people in the leprosaria, differently able, disabled people and all, they don't pay premium. You understand? So it's the program government is doing to help these people. So that is why the premium payment is not a thing to actually depend on. And government workers, people in the formal sector who contribute to SNP, also do not pay premiums. Of course, they have a percentage of their SNP which is used by NHIA. So they don't have to pay premiums. So in essence, you are left with just a few people in the informal sector who pay premiums. Very few people in the formal sector who pay premiums.
Salim, hold on for me. Yeah, hold on for me. Now we'll come back and look at the sustainability of it. So just hold on for me just 1 second. Hello, I have Selem Adonu on the phone, who's the communication director for NHIA. And then I have in the studio Stanley Ajay, who's head of research and advocacy at the Chamber of Pharmacy. But just before we went on the break, I wanted to find out from Selem what would be the way forward with regards to sustainability. And my brother here also have a question. Selem, are you there?
Yes, I am.
So in about, a few years' time, the population will grow. If your scheme becomes very successful, and let's say you have 25 million people on your list, with your record, which means there will be 17.5 million people who are not paying. That's the 70% mark which you were working with. I wonder how, as a state, not your fault, but maybe because you are in the industry, maybe you've discussed it, how we're going to sustain this very good thing that we have. And I think Stanley also wanted to ask you something.
Yeah, very well, Mr. Selem.
Yes, sir.
Yeah, I wanted to find out, so in terms of the payments, the assurances you actually got, as in which timeline are we looking at here?
I like your question. That's a typical businessman. With all we've said, I mean, yours is the bottom line. I mean, yours is the money. Well, I mean, government says that, the money will be released. And, I mean, we've been working with government, and I know our people are always at the corridors of the finance ministry trying to ensure that, I mean, we are taken care of. I mean, so I can't really give you timelines, but, it will come through because the government is aware of the enormity of the challenge, confronting it and confronting the NHIS in terms of, I mean, the recent happening. So we can only hope that in the next couple of weeks, we will have the money released. So we'll do our part. And we should also know that I'm not sure government is happy being talked about in the manner that has been said of it in the last couple of days because of the delay in payment of claims. So I'm sure that, the appropriate people are listening and they are trying their best as well to release the money. That's what I can say. But the assurance is that it's a business partnership. We want to succeed the same way we also want us to succeed. So we help ourselves to help ourselves. So that's it. We will make the money available as and when we get it. We hope to get it very soon, at least from assurances we are having from government.
Good. So, Selem, let's look at sustainability. And this, like, as a nation, collectively, how do we sustain this this scheme, if I may say?
Well, thank you very much again for that question. The scheme will be sustained as far as we want it to be sustained. The National Health Insurance Scheme is not just a few people sitting somewhere and working. It is a national thing. It is for you, it's for me, it's for Stanley, it's for everybody. So what we have to do to make the scheme succeed is that we have to ensure that we expose people who are working in the scheme. The second point is that we have to be serious about our health. How much premium or value do we place on our health? Are we ready to pay a bit more for our health? Or we are just saying that we are paying what we are paying and the government must look for money somewhere to do it. Government cannot go and borrow money from somewhere to fund the NHIA.
No, Selem, hold on. You see, if you're not 18 years old, you don't pay. If you're over 70, you don't pay. If you're poor, you don't pay. So by all these eliminations, we're just left with just 5% who are paying. So I'm saying, unless you take away those legislations, then what is the way forward?
No, we said we have about how many people who are paying, about what percentage?
There's 70% on the scheme who don't pay. They're being carried along by 5% who pay and government levies.
No, not 5%. About 30, around 30% of people pay.
Okay, so
the
30%.
5%, the 4-5% I mentioned has to do with the total collection, premium collection. The premium we pay.
Sure.
The premium collection. That is it. So the 5%, because you have about 70% of people not pay, you are less about 30 thereabouts, So that's the problem.
Okay, so let me just say, let's say 30% who are carrying the 70 by way of age, economic or disease. How then do we sustain it?
You need to also understand that the financial driver, mainstay of the NHIS is the levy. And everybody buys things and everybody pays the levy indirectly. Mm-hmm. Then if you buy, goods and services, you get that. So the 7% do not pay what we call the premium, the insurance premium. The 15, 20 CDs or 10 CDs in some cases, you pay yearly or annually to renew. those people do not pay. That is just the difference. And the 30% who pay, if you put all the pay together, this will be our total expenditure, revenue expenditure. You know, it is just about 4-5% of the entire revenue base of NHIA. That's the point I was making. But so I'm saying that we will sustain it. The scheme will be sustainable. You know, as far as Ghanaians want it to be sustained. That's why I was raising the issue about the value we place on our health. We are able to do a lot of things which people may describe as unnecessary. But when it comes to paying for our health, then we tend to shift it towards, you know, maybe government or somebody. But government, in the last couple of days, we've known that it becomes a burden. And there are a lot of things we have to do. So there are discussions on when we have meetings, we have conferences, we had an international conference. And it was unanimous at the conference that, you know, participants and experts from across the world lauded government initiatives because our scheme is homegrown. It came from local demand, local expertise, etc. No wonder people come from all walks of life, from all countries across the globe to understanding what we are doing. You know, and the unanimous call was that the NHIA should be giving more funds. And people even went to the extent of saying that the levy should be raised by 1.5%, and others say that we should have more money for more sources. So these discussions are ongoing. And in the end, I'm sure government will make, you know, a pronouncement on it. And government has given us assurance that the scheme will be helped, the scheme will be supported. And I remember in 2012, President Mahama, 2012, close to the election, President Mahama said that government was committed to making the necessary budgetary allocations to ensure that the scheme works.
So you are saying that so far with the levy and the 30% being collected, you have enough money to run the scheme?
Well, you know, the money is collected, the money goes somewhere, and the release of that money from that source is what is delayed. It doesn't mean that there's no money there. The money
I'm not only talking about the pharmaceutical.
What I'm saying is that I think you need to understand. What I'm saying is that the money is collected, it is put somewhere. We call it a consolidated fund for government. Government has to cost the release of that money to us before you're able to pay. So if the release doesn't come, the money could be sitting somewhere. Our money could be sitting somewhere. For example, the money they release to us is our own money from the levy. But it is government money. So that has to go through a certain process. So we have some of that money left to close last year.
Salam, I have 20 seconds. I'm not talking about pharmacy. I'm talking about running the scheme. You're saying that the levy collected and the premiums paid now is more than enough to sustain it?
I wouldn't say so. But of course, everybody will make do with more money. The more money we get, the better things work. So the same way you will be happy if your boss increases your salary, you will also be happy if you have more money to run the scheme, to make things easier and things better.
Well, Salam, thank you very much for that education.
I'm very grateful for the opportunity.
Thank you. And I give you the last word to probably go and tell your members that all is well.
So in going forward, what I would suggest is that, or what we are, for example, proposing is now it's a national project or a national program that we must all support. But as we support, we must as well make sure the people who are stakeholders in it are equally not run at ransom, or they are not badly affected by what they do. And in order to make sure there's some sense of urgency in by way of paying, for example, it's possible we can even put some penalties on delays. So maybe there's a 1 month delay and there's a 5% interest rate on, so that by the time you pay, you realize that any delay in not paying will attract something, so that some sense of urgency will be infused into it. So it's something we are all in support. It's a good program, but whilst we tout the credentials and achievement of health insurance, we must not forget that there are also issues we must address.
Stanley J, thank you very much. And penalty, why not? To create a sense of urgency, I'm saying that maybe you should just sit down and see how best they can pay money in less than 90 days, even though people have signed on it. Times are hard now. As I always say, my name is Nanan Saka, this PM Express, and thank you for watching. Tomorrow we'll be back to do it all over again.